clinicians leverage the potential of modern sulfonylureas in managing type 2 diabetes, especially given that SUs are old treatment, but you have metformin, you have freshly available dapagliflozin at economical cost, you have freshly minted sitagliptin now coming because the patent has expired. Soon other drugs also the patent will expire. In the era of these drugs, how can clinicians make sure that the economical sulfonylureas are used? Dr. Sandeep, your view.
So, sulfonylureas, I usually use the analogy that if you have the asking rate in a cricket match at T20 is high, you would obviously send your best batsman in so that the asking rate comes down, and then you can take it from there. We all know that A1C reduction is best with SUs. The usual A1C reduction with DPP-4 inhibitors will be something like 0.5, at most with approximately 1 when you add it with metformin. Triple drug at most 1.5. So when you want the sugars to get controlled, I am all for not continuing SUs, if possible, withdrawing them later on, giving all the other drugs, the oral GLP-1s, but I know what works initially is the SU. So I think it is most important, and even most 70% of our patients in our OPDs will be on SUs. Very few of them may be weaned off SUs later on in their diabetes once their sugars are controlled. So I think SUs are here to stay.
Well, I think that's a wonderful analogy. But I'm not sure Dr. Tejal likes the cricket analogy, because recently I posted on Twitter, I asked everybody whether India is going to win the match or lose the match, and she wrote that, is there a don't know, don't care option? So Dr. Tejal, non-cricket analogy maybe on sulfonylureas. But I'm going to end with another cricket analogy, please.
I think sulfonylureas are an indispensable part of our armamentarium to manage diabetes. And I think the more the merrier. Why should we choose one above the other? So when we have a cafeteria of choices, we pick the one that best suits our patient. There are many instances in my patients where I end up using a lot of sulfonylurea, gastric upset with metformin, gastric upset with DPP-4 inhibitor, UTI with SGLT2 inhibitor, does not tolerate a GLP-1 analog. We have so many patients like that. And sometimes, in spite of being obese, insulin resistant, sometimes that is what we do need to use. And another situation where I use sulfonylurea a lot, and which I'm very happy with, is just today. We had a patient who was diagnosed diabetes for the first time, went to Dr. A, and insulin was prescribed. Obviously, they took my appointment the next day because nobody wants to start insulin. So when people come with pretty high blood sugars at the beginning of their diabetes, also sometimes using a sulfonylurea, getting down the sugars quickly, is very reassuring for the patient, because they feel that this is something that can be managed, because getting diabetes is pretty frightening. So I think it's an indispensable part of diabetes therapy. Like Dr. Julka said, it's here to stay. It's not going anywhere soon. And I think it's great that our patients have a lot of choice.
I think well said. I think it's very important to put SUs into perspective in the modern era. Dr. Prem, your thoughts?
Yes, sir. So I would begin with our mentor, my mentor and sir's mentor, Professor S.K. Singh, sir. Sir always used to say that sulfonylurea receptors, they are the God-given receptors that we have, because all other SGLT2s, be it a DPP-4 inhibitor or be it a acarbose, voclibose, all these things are like blocking a receptor or blocking an enzyme, and that's how it's functioning. But here we have already a God-given receptor, and there is some orphan ligand in the body itself, isn't it? That's why the receptor is there. So we always say that it is definitely one of the God-given mechanism, and we are just triggering that God-given mechanism to have a better glycemic control. So all said and done, I agree with both the speakers, Sandeep sir and Tejal madam, that SUs are definitely going to stay on. But the most advantageous thing with the newer molecules is that since because of the advent of the newer molecule, we are able to keep the dosage of the sulfonylureas much lower. Like going older days, 6 mg, 8 mg and all. Now, mostly with the 2 to 3 mg at the maximum. Mostly most of my patients, I would say that glimepiride up to 2 mg, they are getting well controlled with the adding up with the newer OADs also. So that is another benefit. So we can get a good glycemic control, a prolonged glycemic control, and even delay the onset of the insulin initiation, because we know that that is one of the toughest job that be it at whatever center you are, or whatever clinician you are, that is one of the most toughest job to convince a patient to start the insulin. So that is how I think, or that is the perspective that we can take. So it is never going to go away. It is going to stay with us, but with a wisely you can use it with the lower dosages, and hence we're giving a good glycemic control, a prolonged durable glycemic control, adding up with the newer remedies.
Thank you. And like I just want to talk about sulfonylureas, what Dr. Professor R.V. Jayakumar used to say when I used to work with him. He used to say the punishment should never be one for everybody. The punishment should fit the crime, because somebody is let off with a fine, somebody is jailed for a year, somebody is given some other punishment. Similarly, he said for cricket, for example, in a cricket team, if a team performs badly, you're not going to sack the entire team. You're going to, some of the older players, just because we are old, you're not going to sack. The older players have a lot of steam in them, you are continuing to let them play. Similarly, if a younger player has made a single mistake, you're going to continue to let them play. Similarly, I think sulfonylureas, the older sulfonylureas can be retired. Glibenclamide, they're not performing anymore. But if you see the newer drugs like gliclazide and the very new young sulfonylureas like glimepiride, yes, they're still, compared to the sulfonylureas, history of sulfonylureas, they are still relatively younger drugs. They are doing a good job. They're controlling the blood glucose. They have, glimepiride has shown cardiovascular neutrality. If you look at the data with, say, linagliptin, and gliclazide also has benefits. So I think the newer generation sulfonylureas can be continued. And my practical tip is a very low dose of glimepiride or a low dose sulfonylurea works very well in today's practice to control the blood sugars effectively. So let's continue to use these agents which have been there for years for the benefit of our patients.